versus?
I'll show you this case as it kind of started, which was with this CT. And I'll scroll through there just to show you the diffuse nature and the pattern of the pulmonary opacities. There are very few lobules here and there that are spared from this process. I'm not quite sure why some lobules in the right lower lung. So the most obvious is just a diffuse, homogeneously diffuse pulmonary parenchymal hyperattenuation abnormality. There are also some septal lines, as you can see, but relatively sparse. Perhaps a few peribronchial fluid tufts in the lower lung zones, and a little bit of left pleural fluid. The resident who read this correctly, I believe, mentioned that there's also a crazy paving, kind of subtle, but a crazy paving, and went down the differential diagnosis of crazy paving fairly extensively. So what wasn't done was to try to find another, at least another image showing the lungs. So I'll show you, for comparison, that this process is not new. This is 2017. Pretty close to the same in the lower lung zones, as you can see there. And you will see splenomegaly. So, of course, now we know that it's a chronic process, severe but chronic. And there's a question of whether the pleural fluid represents the same process or maybe some lung edema superimposed on it. So, of course, really, the history is like really important here. And when I looked up the medical record and saw that the patient had chronic polycythemia vera, then I intuited that I know what this is for sure, pretty much, which is diffuse extramedullary pulmonary hematopoiesis. So that may occur in myelofibrosis, but it may also occur in polycythemia vera and may be associated with pulmonary hypertension, which this patient has. So I'll give you some context over there for the polycythemia vera and some findings related to that. No surprise that there is pulmonary hypertension. So I don't have a biopsy, but I'm pretty confident that's what it is. If you want some articles to read, here's a really nice one. And here's a nice one that also talks about the possibility of doing a sulfur colloid scan to show uptake in the lungs. So this is group 5 pulmonary hypertension, but a dramatic case of what I'm pretty confident is present, which is diffuse pulmonary hematopoiesis. So we've shown a couple in the context of at least myelofibrosis. I've shown one, I know Travis has shown one, and the findings are pretty much exactly what you see here, to a greater or lesser extent.
Wow. Any paravertebral extramedullary hematopoiesis?
Let's have a look. I think so. There's some lymph
and is the pulmonary hypertension, is it thought to be due to just high output state, or what is it from?
I'm not really sure what it's, maybe multidimensional, small vessel disease. I don't really know for sure. Now that you ask about looking for extramedullary hematopoiesis, I would say that if anyone sampled these things, I wouldn't be surprised that there's extramedullary hematopoiesis in those nodes too. It's an unusual place for nodes. But I'm not entirely sure that it's known exactly what the nature of the small vessel disease is, but the association with pulmonary hypertension, which can be severe, is well known. So in group 5 pulmonary hypertension, a variety of hematologic orders may produce this, and there are all kinds of theories as to the actual pathology of and the pathogenesis of the pulmonary hypertension. Maybe it's likely multidimensional. Okay. This one is interesting. So, kind of a long history, but I'm going to shorten it a bit by telling you that a lot of focus was paid to the presence of this right middle lobe opacity. So let me actually go and see if I can find some thin cuts with that one. And I'll just scroll through that. You can see the morphology of this right middle lobe opacity. Notice that in fairly close proximity to the opacity in the right middle lobe are some additional smaller nodular opacities. And then I will show you that there are a small number of sub-centimeter nodules in the lungs, some of which, like up here, touch the pleural surface very closely. And those nodules have been present for quite some time, and there are quite a few of them. Not all of them, but quite a few are in relation to the pleural surface. And there's another one here. Let's see if I can find it. Or in a couple of places, I thought there was some opacity, maybe very close to bronchovascular bundles as well. So they did a CT-guided biopsy, and I'll show you some pathology in a moment like that. And what was raised on the basis of that was potentially a lymphoproliferative disorder of some kind. And they were worried about lymphoma. But as I'll show you in a moment, the pathology was inconclusive, so they went on to a right middle lobectomy to take that out. So let me show you again the appearance of that opacity. I just want to go back to the thins because there are a couple of places where I thought I was seeing potentially a variant of the sarcoid galaxy sign. So just in proximity to that larger opacity are some smaller opacities. And there were a couple other places where I thought I might see a septal line or two. I was swayed in part by the presence of these other nodules, some of which are subpleural, in thinking about sarcoid, but obviously there's quite a difference in the appearance of the small nodules versus that dominant opacity. So here is the pathology report. And you can see that when the lobectomy was done, there was, and I'll show you right now alongside it, some lymphoid abnormality, but dominantly there are non-necrotizing granulomas. So here are, in the biopsy, lots of, and I don't know why, lymphoid follicles that you can see here. But then on further evaluation, I'll just go through these and you can look at the annotations. There were lots of sarcoid granulomas with, here you can see a lot of collagenization, the deeper pink, very typical of what one might see with sarcoidosis about the granulomas. Very dramatic here. So this would be super typical of sarcoidosis. So the diagnosis is sarcoidosis, even though there's some lymphoid follicles and no one quite understands why. But there were no findings otherwise on any other workup to suggest the patient has a lymphoma. So they did the bone marrow and some other things, as you can see over here. So kind of interesting. I don't know why they have small nodules, which I like to think are sarcoid, and then a dominant large opacity, but consistent with sarcoid in that right middle lobe. So kind of interesting. Took a while for this whole case to evolve. Here's another one for which I have nice pathology.
Quick question. Was that patient on any drugs for their disease, like a TNF-alpha inhibitor? I may have missed that. Yeah, with the UC.
Bowel disease, right? No, I didn't find it. I actually think I might have looked for that.
Yeah, it sounds like they already had a cololectomy, so maybe not.
Yeah.
Okay.
Yeah. So rather peculiar. Okay, here's a case. Let me show you the images that just preceded biopsy. And I'm going to put 2016 alongside. So as best I can tell, the story started in 2016 with the observation in part of ground glass, pure ground glass nodules in the lungs. And I'm not sure what happened, but they did a follow-up, which is obviously quite a lot later. So here is the one that attracted most attention. I'm not quite sure why, maybe because of its size. So let me just make this one big. So this one compared to that one. And you can see the change in size. So what followed that, I will show you in a moment, was a CT guided biopsy of this, a PET scan, and subsequently a lobectomy. Now, I might as well tell you, for example, that there's another one right there. It's smaller than the other one, but it too has increased just slightly over 4 years. So no surprise that we have this pathology. So here's the needle core biopsy. Here is a slightly bigger version of it. And you will see that we have abnormal cells going along the interalveolar septa, very consistent with adenocarcinoma in situ. And then just for more nice images, here is low power of the nodule in the right upper lobe. Now the lung is collapsed. But again, you see the same thing where you have interlobular septa, and I'll show you a bigger version like that, along which these cells, these tall cells, standing up tall cells are growing, very typical of lipidic growth. There's a really nice image of the appearance of lipidic growth of cells of adenocarcinoma in relation to the interalveolar septa. So a really nice correlation between the chest imaging and the pathology. However, I was really surprised that they went as far as taking this out. Over time, this has grown just slowly. No solid component is present within, and I'm surprised at the workup and the biopsy and the resection. And one other thing I should mention, I forgot to mention, that the pathologist found in the lobe many foci like this, separate from that nodule of adenocarcinoma in situ. No surprise. So kind of a nice imaging case, but I'm surprised in an older person that they actually went and took that out. I think that could easily have been followed rather than going that far. Any comments about that, guys?
Well, agree with you on the management. I mean, if for lung cancer screening, you wouldn't, that's a lung RADS 2 until it's like 3 centimeters. And if it's growing slowly, you typically watch it.
Yep.
And just another comment is that the agreement between AH and AIS can be quite variable depending on pathologists. But I mean, if they took this out, it's less, but especially on lung biopsy, just like a percutaneous biopsy, it can be quite, that differentiation can be more difficult than people think.
Yep. I don't think this patient was done a good service. I don't think myself. They could have just swallowed this thing. It's interesting that when it was first observed, it was around 6 millimeters. If one followed the Fleischner criteria for GGO, no follow-up is suggested, at least for that number and smaller. And if they had not done a follow-up, they wouldn't have discovered this, and et cetera, et cetera. The slight growth over time. All right, those are my cases.
All right, thank you, Howard. Who is ready next?
I can go. Which one is it here? This one. All right. This one's just quick. It's just a nice example. I think we've all seen it. It's just a pretty example of this. A young male who's got AMLs, and this is just a chest CT I just read this morning, where he has all the kind of classic findings in of TS. He's got the fatty foci in the heart. He's got the lamb, and I have to say, it's variable, but most of the lamb I see with TS patients tends to be not as severe as I see with people who just have lamb versus the TS-related lamb. Again, that may be not true, but that's just my own personal experience. And then it has all these nice ground glass nodules all over the place from these areas of multifocal, multinodular pneumocyte hyperplasia. So just a kind of a nice spectrum of, and these nodules have been stable for many years. Is these type 2 areas of type 2 pneumocyte hyperplasia. Just a nice example of all the findings in TS. This is a case I read the follow-up on, and I think it's very important for people to get terminology correct. So this was a trauma patient, and this was read as a intimal injury, or read as an intimal flap, and the history on all the follow-up and all the follow-up imaging was saying, oh, it's follow-up dissection, because they read intimal flap. I think people can see that this is not a dissection in the standard sense. This is a pretty traumatic, severe shear injury. He was a pedestrian who got hit by a bus. And you can see here that this is, in fact, going to be a minimal aortic injury where there is intimal defect, but there's other defects as well. And then you get this layering or these areas of thrombus associated with the minimal aortic injury. And I called up the team. I said, it doesn't really, it's not going to make a difference. You're probably not going to do anything different, but this isn't really a dissection. This is in the traditional sense, this is not someone having hypertension and there's a disruption of the intima from, this is a severe shear injury that led to a lot more than that. Anyways. This is, I love, this is one of my favorite cases I've seen in a while. And because it just has a lot of interesting findings. So this is a young kid who has a history, and let me just go to the axial. So he has a history of a thymoma, and the thymoma grew back, as you can see here. He also has our nice findings of chronic bronchial wall thickening and tree and bud nodularity, and he in fact does have Good syndrome or hypogammaglobulinemia associated with thymoma. He's a young patient. He was followed up and had not only had some recurrence, some new pleural lesions, and had radiation. They then re-radiated this area. And then many months later, he came in with chest pain, and they're kind of a low risk. He came to the ER with chest pain. They did a coronary, and you can very nicely see that the LAD here is just completely trashed. So the LAD has got a severe lesion here, another severe lesion, for the sake of, so severe lesion here, another pretty severe lesion right here. Additionally, there was a kind of a tight lesion in the diagonal branch. And the other thing I noticed was that there's no vessel here. So there should be an artery that's supplying this region. And I wasn't sure if it was this really tiny ramus, but I presume that there was an occluded either vessel off the ramus or an occluded OM that we just couldn't see. You can almost see a hint of it here. Anyways, so this was a post-radiation. You can see in the lung, the radiation field, and this was the most, and you can see also the RCA is about as pristine as it gets. He also still has his tree and bud nodularity. So this is the most severe case of radiation stenosis I've seen in a young patient. And the nice thing, or kind of nice thing, is that, let me pull this to the side. So I looked at his cath report, and I was a little bit disappointed. because I saw his cath report. So here's just a picture of his 2 LAD lesions. And the diagnostic cath report said that the LAD was trashed, which we said, but the circumflex was, in the first agonal branch, they said was only mild. And they said, yeah, there was a moderate circ lesion, which there was, but they said that the obtuse marginals were fine. And I was kind of disappointed thinking, but then he got a diagnostic intervention and they went ahead and said, actually, no, yeah, the LAD is trashed, but in fact, as I expected, just based on the distribution, that the first OM was completely gone and totally gone, just totally occluded. And so remember, cath it's an imaging modality. It's definitely the gold standard for imaging, but it's still an imaging modality and still read by people. You know, they make errors and miss stuff as well. So, you know, in this case, the CT was a little bit better than the cath, which usually is not the case by any means. But so it's a guy with good syndrome with a thymoma who then developed post-radiation stenosis of his coronaries. And then the last case is an interesting case because it has a nice sinus venosus. You can see kind of pulmonary veins coming into, even the inferior pulmonary vein is kind of directed towards the right atrium. The superior pulmonary vein comes in here. So it's a you know, sinus venosus ASD with PAPVR, undiagnosed. This is an immigrant coming in and has obviously a blown out RV. The interesting thing is I've never seen, it's quite severe pulmonary hypertension, and still debating whether or not, so you could see that his pulmonary arteries here are bad, and they're also, a lot of them are occluded. And I've seen a lot of mural thrombus, and I've just never seen mural thrombus lead to occlusions. So you can see even here, there's just big thrombus in the occlusions. So he underwent heart-lung transplant, and they read this out as just organizing thrombi, and we were kind of debating whether this was truly CTEPH on top of mural thrombus from just having really severe PAH, or this was in fact just somehow having mural thrombus that somehow occluded, because usually, again, mural thrombus doesn't lead to occlusions. So just an interesting case. You can see the very classic blushing, the periarterial or blushing we see with patients with severe pulmonary hypertension, usually patients with PAH, but I have seen it occasionally with people with shunts. Although people with shunts, I've also seen the very zonal areas of hypoperfusion we see with CTEPH. But anyways, I've never seen a kind of a mural thrombus do this before. So debating whether it was two different things or just one. But I don't know if anyone has much to add about that, but that's those are my cases.
All right, thanks, Seth. Those are good.
Interesting.
I don't know if there's much to add about that one. Interesting. I like your coronary case. That's a great teaching point.
Yeah.
All right. We've got Peter and Travis and David.
I've got one that's quite interesting.
All right. There you go. Oh, I got Brian online too. Excellent.
Yeah, so this is a lady who's 59, and she had nodules that were discovered over 10 years ago incidentally. You can see she's got surgical clips in her right axilla, and she has bilateral breast implants. And these nodules, they're clustered and you know, somewhat, I'd say, perilymphatic in distribution. A lot of them are along the fissures, and you almost wonder if you're getting a little bit of a galaxy sign with some of these. You know, you can't really make it out for sure, but these have been there for at least 10 or 12 years and have slowly increased in size. And you can see this was in, well, I guess it's 13 or 11 years now. She had some nodules, so they're just creeping up in size. She doesn't have any lymphadenopathy, but we were going through, you know, is this going to be sarcoid. Somebody had raised the possibility maybe this is some sort of lymphoproliferative disorder. She has a history of inflammatory bowel disease, but that's about it. And the clinician and the patient were both anxious, and so we did a CT guided biopsy of these. And does anybody want to take a guess at what this might be? Any thoughts? I mean, this looks like some sort of granulomatous disease. I would think mostly sarcoid since she's asymptomatic.
You thought maybe they were increasing slightly?
What's that, Howard?
Sorry, you thought they were maybe increasing slightly in size over time?
Yeah, they've definitely grown slowly since 2009, that first study I showed. So that'd be doubling time on the order of years.
Yeah. So sarcoidosis is good, but I'm thinking of other things that produce nodules that can grow slowly over time. One is the entity of pulmonary hyalinizing granuloma. And if something grows slowly but faster than this with nodules in the female, I would think of pulmonary epithelioid hemangioendothelioma.
Right. Yeah, and no history of any other extrathoracic tumor malignancy. And what this turned out to be, because
Travis, before you go on, what was the material in her breast implants? Was it silicone?
It was silicone.
Okay, this could be an inflammatory response to silicone.
Well, it's interesting you say that, David, because the clinician, the pulmonologist, said that when they did a right axillary lymph node biopsy, they ruptured her right implant back in the 90s. And they excised some lymph nodes at some point in time that had silicone in them. And so the question was, could this be silicone? And that was one of the things on their differential. And I was like, well, we've seen acute silicone embolization syndrome. I've never seen chronic silicone embolization, but we did a core, and you're exactly right. Giant cell granulomas, foreign material, morphologically consistent with silicone. So,
wow.
Yeah. So it's like chronic. Now, our pathologist, he will throw citations, and I actually pulled up this paper. Now, annoyingly, this paper talks about a CT, but doesn't actually have the CT in it. But this was actually a patient who had what they thought was mesothelioma based on the description here. They had a bunch of pleural masses and an effusion on one side, and they did a biopsy of that and found that it was a silicone, like a granulomatous reaction. So, yeah, this is all a chronic silicone. Well, presumably, I mean, if we believe that all of the nodules are the same as this one, which they almost certainly are, then yeah, this is a granulomatous reaction from silicone. It's really interesting that it's more upper lung predominant. And I don't have a good explanation for that, because you would think it would be hematogenous and therefore be more in the lower lobes, but it's not. So this was a new one for me.
New one for me. Wow.
And yeah, and then and no lymphadenopathy to speak of. So I guess maybe a little right internal memory node there, which probably has silicone in it too, but that's it. So that's my one interesting case for this week.
Very interesting. Thank you. All right, Peter, Brian, or David?
I have a few quick ones. Huge mysteries.
Item 6.4. 44.5. 43.
This is a 59-year-old lady with heart failure, and this is her chest radiograph, and she has this the new Impella device, which we talked about a few months ago. And one of my colleagues was Eugene Berkowitz was reading this X-ray, and he noted this structure right here. And it looks like it's kind of following the contours of the ventricle. And we will show the CT here. So here it is. You can see it. It's basically right on the pericardium. So I had never seen this before, but this is a It's a cardiac support device, and it's made by a company called Acorn in Minneapolis. It was first developed around 2004. I'm not sure if it's still made actually. It was made in 2004, 2005. Then you can see this mesh kind of sewn around the ventricles. And the purpose of it is to restrict remodeling and dilatation of the LV in patients with heart failure and mitral regurgitation, and kind of provide a diastolic support. They published one randomized trial, the company did, over 5 years, and they got they reported positive results, but it was not approved by the FDA. So I guess it didn't really take off.
We were a test site for that many years ago, and the surgeon, so we saw them not too infrequently, and our surgeon said flat out just didn't work.
Okay.
And I haven't seen one in, I don't know, 8 years, 7 years at least.
Where were you when you guys were the test site?
University of Maryland.
Oh, Maryland. Okay.
There was one of multiple centers that were part of that project. Yeah.
Acorn trial. Okay, and then these are just kind of quick. This one is a patient with HIV/AIDS. This is actually the CT from a few, like 2 or 3 years ago. Just if you go to the upper lobes, innumerable nodules. A lot of them are cavitating. This grew MAC and both MAC and mycobacterium kenzii combination in cultures. Just kind of expected appearance of those. You see very few in the lower lobes.
Do you know how common multiple species of mycobacteria are in this population?
What's that, Jeff?
Do you know how often, or does anyone know how common it is to see multiple species of mycobacteria in particularly immunocompromised patients?
I don't. I know the Kenzii is prevalent a lot in the cities, but
yeah,
people get colonized with it. But not sure.
Yeah, I think of M. kanzasii as looking a lot more like TB in most patients.
Yeah. So and they look like TB and
I don't know about HIV, but just the cases of M. kanzasii I've seen often image a lot like TB with the typical cavity.
Yeah.
But yours are neat. They're kind of like little Cheerios.
Yeah, so what I've read about it is there's two appearance. The more common one is the TB appearance with the fibrocavitary lesions, and then the less common one is the nodules with more circumscribed nodules with cavitations.
Okay.
It didn't say which one is which population, but this guy was an HIV.
Yeah.
And then the last one is from a few weeks ago. Patient came into our community hospital, county hospital. No significant past medical history other than diabetes, and this is a young patient in her 30s. She's coming in with cough, shortness of breath, fevers, and so obviously striking cavitation in both lungs, more on the right side, and then as you go to the periphery of the cavitation, you see nice little centrilobular nodules. So as one would expect, this was tuberculosis, active TB. That was a good example. And for an unknown reason, about a week later in her hospital stay, she saw this. So she had a PE, and then she also has LV thrombus, and multiple strokes. So we didn't really, the clinicians didn't really have a good explanation for maybe perhaps DIC, but what the link is with TB.
How long did that patient been sick for? That's pretty advanced tuberculosis.
How long did they, what did you say? How long?
I mean, that TB had clearly been there for some time.
Yeah, I don't know. We didn't have any prior imaging of her.
Okay.
I mean, is it, sorry.
Yeah.
No, is it possible that the lung is so necrotic that material got into the pulmonary vein and embolized? I mean, that is just, I've never seen that or heard of that before, but I mean, I've seen mucor embolize, but I was just wondering if there's any evidence of soft tissue in the pulmonary vein now. Well, not really centrally.
Yeah, that was one of the thoughts, is that the mass in the apex could be tuberculoma, but there was nothing on the initial scan. So there's nothing in the arteries on the initial scan or in the LV apex. And then about a week later, it's there.
Strange, very strange.
She didn't have a PFO from that massive PE throwing paradoxical.
I didn't see that. I didn't see that.
Well, at least not, I mean, we don't, yeah, maybe on echo, who knows?
Yeah. Yeah. And usually, I mean, I was surprised because usually a lot of the patients with this much that I see with this much TB, they're immunocompromised. But this patient didn't have anything known besides TB, besides the diabetes, which is immunocompromising. Yeah, that's all I got.
Awesome. That's an impressive case. All right, David or Brian, either of you have any cases this week?
I do not.
All right, David?
Sorry, no.
All right, I'll show a few. All right. So this is an interesting case. This patient's in his 60s, I think, developed a cough. He had actually I'd been hanging out in Arizona for a while and was planting some trees and digging in his dirt and developed a cough. He's a retired veterinarian, doesn't smoke, doesn't have any other real major medical disease, and got a CT scan that looks something like this. See, we have sort of a lower lobe predominant airway-centered process. We've got little branching nodules, some mucus plugging, and as we go down a little bit more, you'll see there's some peribronchial, just small amount of consolidation, but very much an airways-looking disease. So he was treated or worked up for cocci in Arizona, all negative, and he had a bronchoscopy. So then he came back to Wisconsin and got seen here in pulmonary, got evaluated, and was still having symptoms. So he ended up getting a bronchoscopy that showed some eosinophils and also grew out aspergillus, like the usual one, fumigatus, and was put on an inhaler and a little bit of that, but didn't get a lot better. And the question was, wasn't immune suppressed? Is this aspergillus infection? Is this colonization? I will show on his soft tissue windows, you'll notice there's some mucus plugs that are denser than blood pool. There's one there, and there's a couple other ones as well. Assume it doesn't jump around on me here. There you go. Whoops. Just use the keyboard here. One out there, and if you look around, there are a couple of them that are a little bit dense. No asthma, no cystic fibrosis, but he's got this big blob here, and on the bronchoscopy they did notice some thick, tenacious secretions, and he reported later on, just when he coughed up stuff, it was pretty thick. So the question was, and we reviewed this in a multidisciplinary conference, is this ABPA or is this something else? And I think it's a great look for ABPA as far as the dense mucus goes, but it's absolutely the wrong distribution. It's very lower lung predominant, and there's really not much bronchiectasis. There's a little bit, a little bit there and there, but not like we typically see where it's more varicose. But he had elevated IgE in his blood, which of course correlates nicely with the activity of this. So the consensus diagnosis is this is ABPA, but it's just in a very strange distribution. And I think it was a delayed diagnosis because of the confounder of the digging around in Arizona, not Coxey. Have any of you, I mean, we've seen a couple atypical cases. I've seen a unilateral case, but has anyone seen this really striking basal predominance of ABPA?
I've got two cases, not with the basal predominance, but with, like this one, involvement of smaller bronchi and without bronchiectasis. So not the distribution, but otherwise like this. Yep.
Yeah, and the clinical findings fit perfectly, and I think the dense mucus really just, I think from an imaging standpoint, really seals the diagnosis. I mean, without that, it just looks like either chronic aspiration or some kind of airway-centered infection or something like that, maybe mycobacterial disease. But it's interesting too, because apparently there's some criteria, I don't know how well they're accepted or widely they're accepted, but requiring a diagnosis of CF or asthma, neither of which he has. So,
but Jeff, all he needs to get those precipitants going is to have aspergillus living in his airways and irritating the mucosa and just getting an allergic response to it. You don't really have to have the mucus plugs even. Aspergillus will give you that allergic response. So one question is he smoking marijuana and delivering aspergillus to his lungs and then aspirating, the infected secretions into his lower lobes? So typically the cigarette distribution of, or the marijuana cigarette distribution of aspergillus airways disease is upper lung, but he could be then secondarily having those secretions drip back into his lower lobes.
Yeah, he's a non-smoker, and we don't have recreational marijuana here in Wisconsin, so.
But that doesn't keep people from using it.
Well, I know. But he doesn't report using anything.
I can refer you to a number of sources in Wisconsin where you could buy all the marijuana.
You just go across the state line to Illinois. It's easy. But no, he's a non-smoker, doesn't use any illicit drugs or anything like that. He sort of has an allergic phenotype, but just doesn't have asthma or CF, which traditionally are criteria to diagnose ABPA.
Right.
But yeah, and you're right about the mucus plugs. I have cases where the airways are cleaned out, but they still have the diagnosis. But I think in this case, the dense mucus really, if you didn't have a working diagnosis, would really point you to it, or at least to evaluate for it, even though the distribution is kind of upside down.
Right.
All right.
Yep.
So that was kind of an interesting case. Yeah, it was a fun one. Yeah. This is just kind of a classic case, but a really nice example. And I don't have a formal diagnosis yet. So this is, let's see, these are about 3 years apart. And this is a woman in her 70s who had some shortness of breath. And I'm not sure why it never got worked up. I did not dig around so much, but had shortness of breath and underwent a CT scan back then. And you can see there's a basal predominant lung disease. It's ground glass predominant. But we see dilated airways, we see some traction bronchiectasis, and there's a subtle texture to it, so it's got some reticulation. And you can see some really nice relative subpleural sparing in the bases. You'll see a little bit of debris in her esophagus, but nothing terribly exciting. But I mean, I think all of us would easily call this an NSIP pattern and strongly consider a connective tissue disease, especially in this patient demographic. For whatever reason, I don't know if it was she was seen elsewhere and we just don't have those records, or chose not to follow up. Anyway, she presented again with worsening shortness of breath, and you can see how this has progressed. And we don't often serially image all our ILD patients, especially if we're following them with pulmonary function testing. But you can see it's become coarser, and she's lost more volume as we go down in the lower lobes. You'll see the displaced oblique fissure there on the right. And the traction bronchiectasis has also increased and almost out of proportion. So when you see this very central traction bronchiectasis, I think it's a great finding for NSIP. And you see that subpleural sparing is somewhat preserved. It's actually quite nice there. So just over the course of 3 years, this is fairly extensive progression of NSIP pattern of fibrosis. And many of the connective tissue diseases, especially when they're managed with normal medications, a lot of times this will stabilize, especially in scleroderma. She still had some debris in her esophagus, so I strongly suspect this is probably going to be a scleroderma or something along that spectrum that just hasn't been worked up yet, and I think she's now going to get a workup. And of course, nintedanib is FDA approved for scleroderma and other fibrotic lung diseases, so that's one treatment option. But I think it's important to at least identify if there's more other disease, because managing the connective tissue disease can sometimes stabilize the lung abnormalities. But just a nice example of that. Let me just show the new coronal here. Just showing you the striking basal predominance and that volume loss in the lower lobes, and then that really exuberant traction bronchiectasis. Okay, this is a really cool case. One of my colleagues in abdominal imaging who gets some cases from Peru shared this case with me. So this is a 41-year-old who has this large, complex-looking cystic mass in his right lung, and it is in the lung itself. There's a rind of compressed lung around it, and then you can see there's a small pleural effusion immediately adjacent to it. So in other parts of the world, when you see something like this, you got to think about hydatid disease, and we've seen a few in this conference over time. We don't see much, of course, in the U.S., but what's kind of interesting is, well, what's very interesting is the patient presented at a later date in respiratory distress and chest pain, and what had happened is this hydatid cyst had ruptured. There's the collapsed membrane internally, and we now have this hydropneumothorax with displacement of the heart mediastinum to the other side. And so, I mean, these can rupture, and there's some debris down in that pleural space there. It's probably some of the membrane, but I mean, I've never seen one. We just don't see enough of these at all. Almost all of them come from somewhere else. And then this one causing sort of a acute presentation with the displacement and the overinflation of this right pleural space.
Wow. Does that count as a water lily sign?
Yeah.
I don't know.
Well,
It's nothing like a water lily to me. I never liked that sign anyway.
Yeah. This one
It's
isn't
more
so
like
much floating on the surface of the fluid, but someone else, I think, called that some other sign where you see it on axial CT like that in the fluid. But I don't remember what the sign was. Something like a something serpent sign, but I can't remember.
So this is not the camelot sign, is it, or something like that? There's a camel.
It's trying to be one. But
But
it's interesting that it's not really floating so much on the surface of the fluid as it is just inside.
right.
Yeah.
And
But
I
there
think
is a sign.
here may be some of the, I don't know, I think this may be part of the process down in here, these little soft tissue nodules. But yeah, it was nice of him to share that. Really just a cool case. Okay, and then my last case is just one of these eye test cases, which if I give you too much history, I'll give it away. But this patient came in the ED worried about having swallowed something. And you can see right there on the frontal view, there's this rounded opacity overlying the left main bronchus. And if I show you the lateral, you can see much better. There's actually a smooth foreign body where we'd see the left main bronchus here. So this patient takes potassium chloride pills to go along with her Lasix. So it's about the right size for one. So I managed to talk them out of a bronchoscopy since it was, out of a CT because it's compelling and it's in the right place, and pulmonary was fine with that. So they ended up doing a bronchoscopy to pull this out because it clearly looked like one of her potassium chloride tablets. And it's rotated. Let's see if I can rotate. I can't, but that's all right. You can see it. You can see it there. There it is, just sitting right in the airway. And you'd think these would be easy to get out, but it turns out it took them a little bit of time. They first tried to just grab it with the forceps, but these get, a lot of these coated tablets get kind of slimy when they're wet, so they don't get lodged in the esophagus. So it kept slipping off. Then they tried a basket behind it to try and pull it up. Finally, they just got some really good suction and were able to dislodge it. And at that point, they were able to pull it out. But there it is, all becoming all kind of mushy. They just kind of sucked it out in chunks. But I don't know. Iron pills, of course, can cause a lot of mucosal injury. I don't think potassium chloride does too much, but it is probably hypertonic and can bring in a lot of secretions and make it kind of like a mush there. So, but a good radiograph where you know, if you have a high index of suspicion and you're looking for it, it's probably easier to find this. But you know, that's one of the areas. And we had that nice carcinoid case, I think it was last week or the week before, where, you know, in retrospect you wondered if you could see the tip of the iceberg on a radiograph. But that's always a tough area. But on the lateral, it's important to look at the air column and need to try to explain this. And I think it's so smooth, you know, unless it's a vessel, you have to explain that. And that was the tablet there.
Very interesting.
Yeah, it was a kind of a fun one and easy.
It's interesting that your esophagus is a bit dilated, maybe more than just a little bit, with air in its lower one half at least.
Oh yeah.
I was trying to determine whether there's a hernia there or something. So whether she has something with her esophagus that might have contributed to the aspiration of it in the airway, I don't know, of course.
Yeah, and she was very, I think she was in her 90s, so there's high rates of esophageal dysmotility in that population. And her heart's a little generous too, so maybe there's some, you know, so who knows if that happened. But those pills are pretty big, so easy to aspirate.
Guys,
right.
before we, can I ask a general question? I'm glad Howard's on because he's an expert in ECMO. I've seen a number of cases of people who are put on ECMO for bad heart problems like acute heart failure that's really devastating. They don't have lung disease, and once they're put on ECMO, their lungs just white out to the point that you can't even see heart borders. And I wonder if you guys have seen this, because I've seen it about 5 times. Is there something about ECMO that leads to just white out of lungs? Got one person who's recovering from that.
Yeah.
It is reversible. Is that a known phenomenon?
Yeah, if you put someone on ECMO and acutely they develop pulmonary opacities consistent with edema, then what one should think of is ECMO-associated left ventricular overdistension. So when you start ECMO and you have all that arterial blood being pumped back into, say, a femoral vessel, it may lead to an acute left ventricular afterload problem, sufficient to produce left ventricular overdistension, left atrial hypertension, and lung edema. So that is a potential explanation for that phenomenon. Typically, they know about that. So, for example, let's say you saw that, and you also saw that they had placed a left ventricular impeller device, then you can suggest even more that it's ECMO-associated left ventricular failure, because they want to decompress that left ventricle with the impeller device. So the impeller device is not intended to improve ejection fraction, but rather to decompress the very over-distended left ventricle. So ECMO-associated left ventricular failure, if you will. Does that sound right, David, in terms of timing?
Right, because these guys, the current ones, have impellers in place too. So that's perfect. Howard, thank you.
Yeah, I was going to say, I thank you for that explanation, because I've seen that. We actually have 2 COVID patients on ECMO right now, and one of them has some pretty white-looking lungs.
David, if you have patients and we think that's going on, you know, I'm interested in lung edema from the point of view of, can you distinguish hydrostatic lung edema from acute lung injury edema? Now, with the ECMO-related left ventricular problem, that ought to be hydrostatic lung edema. So I'm really interested if you have cases that really seem to be that entity. I'd like to be able to look at the radiographs and if you have a CT, just to analyze the pattern of the lung edema. That could be potentially interesting.
Very good. Okay, I'll mobilize those cases. Thanks, guys. That was wonderful. Thanks.
Thanks, everyone. All right, we'll talk to you next week.
Thanks, everyone.